Hello, everybody. We might get things going. Thank you all. My name is Jackie Richmond and I am the Program Manager for Workforce Development. So the irony of this situation is not lost on somebody like me. Anybody who knows me knows that I talk. And I talk and I talk and I talk. So I'm asking my poor people to talk very, very quickly. So hang in with us. There is a question time, hopefully after each session. But I want to thank all of the workforce development and health service delivery partners in the room and online. We have asked, I will take responsibility. I have asked an extraordinary amount of you over the last 4 years, and you know, you're all my friends as well. So you've had that burden as well as not just a working relationship, but a friendship. So I thank you for all your support, particularly when we were locked in our houses in 2020 and 2021. And those of you who were roaming free genuinely helped. You really did. So I'd firstly like to, so we've got 15 of our projects presenting today. I have asked, as I said, an extraordinary amount of them to summarise their infographics. So you will see, I'm a nurse. I don't know a lot about other things. I'm a very good nurse anyway, but we've learnt a lot about infographics. They're actually quite hard to do. And certainly getting them printed and delivered is also another great challenge. So I draw your attention to these infographics, the workforce development, and then we've got client engagement, and then models of care are all over here. So the partners have 5 minutes to talk about their infographic, the highlights package, and then we've asked them to reflect on, if you were to do this again, how would you do it differently? Or what would you do differently? Because we think all the way through ECA, we've asked for people's reflections almost more than we've asked about outcomes, because we're so interested in the journey and interested in capturing those things that have worked and why they've worked. And if they haven't worked, why didn't they work? So I really thank my partners. I hope this is the last time I ask anything of you, but I doubt it. Firstly, I'd also just like to say that we have people online. So I wanted to thank Wanada. So Wanada's poster is over there, and I'm hoping Peer-Based Harm Reduction WA might be able to take their poster back for them. So we have Jill Rundle online, and I'd like to thank Jill and Caroline and Kim for all their work. Prompt from South Australia. So Lucy and Erin, Catherine and David, Deb, Lisa and Kerry for all their incredible work on this great project. Search 2, so Miriam and Julia also couldn't be with us today, and Tascard. So Bethany and Rob have both left Tascard, but Cam is still there. We thank them all very much for their work. I have allowed 2 of my projects to go into another session, into Mark Stuve's session. So that's the Checks project from Victoria and also the NOX project. So they're all acronyms. So they're all going in the acronym session, which is at 4 o'clock. So I still love you as well, but I let you go somewhere else. But I've got Morris anyway, so I keep Morris for another project. So without any further ado, we've got Anna over here, who's my right-hand woman for all things evaluation. And she's also she loves metrics and numbers. So she's got the timing job. So I'm going to hand firstly to Jacqueline De Bravo, who's going to appear. So Jacqueline, are you there?
Yes, I'm here. Sorry, Jackie.
No problems. Welcome. Your 5 minutes starts now.
Excellent. So I'm Jacqueline Del Bravo, and I was the project officer for Hepatitis WA's Regional Clinical Development Project that we started in 2020. So our project was to improve patient outcomes for people living in regional WA with hepatitis C. And we went into 3 regions, the Goldfields, Pilbara and Wheatbelt regions of WA, covering over about 2,000 kilometres. And we did audits of patient management software in GP practices. We also provided GP practices information on testing and treating, how to set up pathology favourites for reflex testing, and also patient management templates and billing for hepatitis C treatments. We also developed a referral pathway for a bulk bill telehealth private gastro consults in Perth for people from regional WA, and developed a range of patient resources. So because of the pandemic, my regions increased, and I was able to contact about 35 practices in those 3 regions. And 32 of those practices, we sent up resources to them. So we sent up the ECA Australia practice toolkit. We sent up the flyers and patient questionnaire that we've developed, posters, a mouse pad with some easy information for GPs on testing and treatment. And out of those 32 practices, 11 practices signed MOUs with us to do the audit of their patient management software. And from those 11 practices, we identified 10 Hep C champions. So these were the people that got trained up on how to do the audit, and also to hand on the resources and information to the GPs. And in all practices bar one, the champion was the practice manager, and that was mainly due to how busy nurses were, especially in those early days of the pandemic, because we started our project in early 2020, and also because practice managers don't work with billable hours or time, so they had a little bit more flexibility. So I worked with the practice manager one-on-one or remotely to guide them through doing the data audit, and then kept in contact with them for the recall. So when we did the audit of the data, we did 3 sweeps. First up, we looked for patients where the doctor had actually indicated on the drop-down box that they had a diagnosis of Hep C. The second sweep looked for patients who had risk factors, and the third sweep looked for patients who were on opioid replacement treatment therapies. And once we'd identified those patients, we looked in depth into each patient's records to see whether they needed to come in for testing or treating. So we identified 35 patients with risk factors who'd had no previous Hep C testing. We identified 9 patients who had a positive antibody but hadn't had RNA testing done, and we identified 12 patients who had a positive RNA test, but there was no record of them having treatment. So to think about what we might have done differently. So if we could do it again, probably might be a good idea to trial incentivizing the project, an outcome-based financial incentive, because one of our biggest issues and challenges was the Hep C champion finding time to actually recall the patients after we'd done the data audit. So maybe if we had given them some financial incentive, that sort of just may have bumped us up a little bit higher on their priority list, but we just don't know. The other thing was visiting the practices in person. That was our original plan, but due to the pandemic, I wasn't able to travel to all bar one practice. So that may have made a difference. I may have been able to do some of the work for the practice manager. I could have done the data audit, just handed them the list of patients for recall, or maybe even recalled the patients myself for the practice. But on the other hand of that, because we did have the pandemic, I was able to broaden the areas. So originally the project was designed to just go to 2 towns, Port Hedland and Kalgoorlie were our 2 towns. And because of the pandemic, I was able to visit remotely or virtually 15 towns and very remote towns as well, and then work with more practices. So there was a benefit to doing everything remotely, and also possible benefit if I had gone there myself in person. So they're probably the things that we've identified. I don't know if I've gone over time. I haven't been timing myself, but I haven't heard a bell go off. So I'll hand over to
there we go. We were about to do that. Bing, ding, ding, ding. Jacqueline, thank you so much. And thanks for putting that positive spin that although There were bad things about the pandemic. You know, you've also managed to expand your reach. So thank you very much. So anybody who would like to ask any questions for this project, Matt Armstrong, are you in the room? Matt, there you are. Hello, nice to meet you. Matt can answer any of the questions. Phil, Jacqueline, just hold on. We do have a question.
Yep, quick question. In the risk factor section, we've struggled to work with GP software to actually identify risk factors that are coded properly. What did you define as a risk factor, and how sensitive was it?
So for the risk factors, we sort of looked down in the conditions, you know, in the drop-down box, and we sort of pulled up anybody who may have been identified as, not my words, the words from the software, drug abuse, drug-induced hepatitis, there is hepatitis infectious, jaundice hepatitis, cirrhosis, or intravenous drug abuse, and also abnormal LFTs. So just depending on what software you use, you can sort of have a look at those different criterias. And also with best practice, we developed a search query, and we could enter this search query into best practice and pull up anybody who had had a hepatitis C test in the past, and then look through to see what those results were and whether they needed further testing.
Thank you, Jacqueline. And Jacqueline certainly has become our chef in the best practice kitchen. She's been creating recipes that we've used in other projects. So we're incredibly grateful, Jacqueline. Thank you so much for getting us off, kicking this session off. I would now like to ask Erin, sorry, can't do two things. Why is it not moving? Erin Oliver Landry to speak about her project. There we go.
That's right. Thanks. It's quite humbling to be in such a big room with so many passionate and clever people. I'll do my best to talk about my small project. I led sort of a different type of peer education project with myself, a GP, heading into a number of different general practice clinics in the northern suburbs of Adelaide, which are higher incidence practices for people living with hepatitis C. We approached 108 practices and were able to gain access and invitations in to 38 practices where we ran lunchtime sessions led by myself and accompanied by the local hepatitis nurse who sat in the community, but under the sort of auspices of the tertiary setting. We engaged with 120 GPs. And so what we did, we provided free lunch, but an informal chat with a bit of a PowerPoint, provided resources, which did include the EC toolkit. We focused on increasing screening, touched on stigma, aimed to reduce and educate on the DAAs and increasing screening. As I said, we reinforced the treatment pathways if GPs weren't comfortable or confident, and also provided supports for patients that they may be making diagnosis with. As a later sort of endpoint, we also offered to provide audits by the nurses within the practices, but due to COVID and workforce, the nurses sort of weren't able to kind of follow up on that. So it's interesting to see that you used the practice manager. We were sort of targeting the nurses, which was challenging to get access to throughout the pandemic. The project ran from February 2020 to 2022. We did have to pause twice for COVID lockdowns, not as much as Victoria, but still played an impact. We felt we did reach the sort of target population of GPs that we were aiming for. So only about 17% had prescribed the DAAs to any of their patients. And we thought kind of coming to the general practices, we sort of removed that self-selection in terms of professional development, and we had really good engagement sort of when we did get through the doors. We did pivot a little bit for COVID and tried webinars, but I found the engagement was much different and more involved when we sort of actually sitting at a table, sort of chatting. And often, you know, the nurses and the GPs would chat about common patients that they'd referred and sort of seen back again. So it was different, and it was pharma free. So there was a different vibe definitely in the room. And I think, yeah, the engagement, GPs, despite the COVID influence of information overload and the burden of it for GPs, they definitely were engaged, interested, and sort of willing to take the information on board and sort of utilize it in their day-to-day practices. I mean, already mentioned, do I have the slide? Which, yeah. So yeah, face-to-face projects are, a challenge in pandemic. However, I think we did fairly well to kind of still get into about 38 practices. I think I underestimated probably the administrative time. However, EC did sort of compensate me for that, but you had to be flexible of any day of the week, that the clinic found it accessible to kind of go in. We did try different avenues of faxing, emailing, posting personalized letters to GPs. The main thing that got me through the door was literally me cold calling 108 practices and speaking to the practice manager and sort of introducing myself as Dr. So-and-so. And it sort of lifted the profile. I think, well, one, it wasn't a drug rep talk, but we also had the support from the PHN, the CDCB, which is Communicable Disease Branch, and SA Health. So that sort of helped, again, get us through the door, I'd say. If we were to do it again, love another GP champion to kind of go out and maybe roll it out in a different suburb that also had higher incidence down south. And also just to help with the flexibility of offering services. And then I guess in terms of, the nursing to be able to run the audits, evaluation was fairly, I wouldn't say loose, but I guess, not a huge component. I know Anna would love probably if we could have evaluated in a different manner, but we was sort of more informal and made easy, I guess, and less burdensome from GP's end of things to have to fill out surveys and things at the end. So I guess, but if we had more time, that would be one way. Yeah. Thank you.
I don't think we can underestimate the amount of legwork Erin did in that project and the number of phone calls that you made. So we're incredibly grateful for your persistence. You truly are a champion over there. Any questions for Erin? Amanda? Oh, you're doing timing and that's a lot of work.
Thank you. Amazing work, Erin. Thank you for presenting it. Can I just ask, do you think the system Polar might be helpful with auditing your work or make it easier for the GPs to count the outcomes?
Like in terms of if it actually had effect on the amount of screening and
yeah,
sort of
testing and treatment uptake.
Yes,
was that
possibly.
considered
Like
at all?
the
Possibly?
SA Health had sort of said they would communicate with the pathology companies. I mean, there's a number of different ones in SA, but yeah, probably that would
Maybe.
be an
Okay.
outcome.
Thank you.
Potentially. Thanks.
Carla, have we got time, Anna? 1 minute. Carla, here in the front,
I was just wondering if you found any stigmatizing attitudes amongst GPs to the population, like in the sense of injecting drug use or around hepatitis C, and did you have to do any sort of attitudinal discussions with the GPs?
We sort of led with a slide about sort of, where the risk factors come from. And I think through some of the other work that's been done in the community of, of other risk factors, we sort of, enmeshed it in that it's not just about sort of, the most common ones of IV drug use that we think about, but there's other ones that overlay. And then we had 3 other specific sort of slides that we talked about how to tackle stigma, what the patient might be coming with beliefs, what the GP might become, and also how do you start the conversation in your general practice, and what are the opportunities within the health screening that you already do that you might be able to really hone in on hepatitis C screening. So that was kind of how we approached it. Yeah.
Thank you, Erin. Thank you, everybody, for questions. Joe from the Aboriginal Health Council of Western Australia.
Hello, everyone. I just want to acknowledge the traditional owners of the land we're on today. I'd like to acknowledge that Kim and I are both from Wajak Noongar Budja, and also like to acknowledge all the lands and nations that you're all from today. And it's important to acknowledge that sovereignty was never ceded, and this always was, always will be Aboriginal land. So ACWA's recently wrapped up our hepatitis C project. its aim was to build the capacity of WA Aboriginal Community Controlled Health Services, or ARCHs, to engage in hepatitis C testing, improve their diagnostic ability, and increase hepatitis C in-house management. We did have a dedicated Hep C project officer to begin with, but with staff turnover and COVID, I've taken the lead as one of a few projects that I take the lead on as a public health clinical nurse. So this project started with a scoping of services, of their understanding of Hep C testing and treatment, how frequently they engage with community, and whether they want training or continuous quality improvement support, or both. While there was an initial comprehensive education session early on in the project, say mid-2020, that led to that clinical audit recruitment we had. Continuous professional development was key to ensure that hepatitis C was kept on the agenda despite competing health priorities. So the education was provided as a dedicated time in what's called our birds and BBVs training, which is training that a long-standing training that was delivered to ARCHs, requesting sexual health and bloodborne virus education for staff of their service. We do about 5 education sessions a year with education experts, both from ACWA, WAC, which is previously WA AIDS Council, and Hepatitis WA. And we would travel regionally to deliver 2-day intensive training courses throughout the year. These sessions were highly received. We had 96.5% of participants recommending this training to others, and 93% expressing confidence, improved confidence in providing information on Hep C to their clients following the training. We've had to adapt that training as well to account for recent COVID travel restrictions that were imposed actually quite late in the pandemic in January 2022 when we had our outbreaks. So the Bird and BBV bites was what we called them. They were 30-minute lunchtime sessions on a Tuesday, held each week to promote new and emerging topics in sexual health. And there were 2 sessions on hepatitis C, but a lot of other ones. One of the sessions I did was chemsex, which was quite fun. Regular engagement and a yarning format was sort of what was key to have participants engage and be on the same level as, I guess, the content experts. And also we gave an opportunity for people to interrupt and ask questions in a space free of judgment. So these sessions are recorded and you can check them out on the ACWA YouTube page. I would really recommend you checking them out. Yay, YouTube. Clinical audits around hepatitis C testing and treatment before and after comprehensive education were had. We had clinical audits with 3 of the outreach clinics with Kimberley Aboriginal Medical Service, OVARS, NARS, I'm saying all these acronyms, sorry, just to keep with time, and Broome Regional Aboriginal Medical Service. These 3 services have shown massive improvements in the Hep C testing rates, namely services who automated the Hep C testing as part of their 715 health checks, keeping in mind that bloodborne virus testing consent is required for the client to proceed. And we also saw RNA testing, antenatal testing, and considerations, and Hep C medication compliance being well understood with medical professionals in those services, even if the diagnosis rates were still quite low proportionally, which shows that ARCHs are continuing to be leaders in comprehensive Hep C clinical management and just comprehensive primary healthcare in general. One thing that was new for this project was in this year, since I've taken over, was advocating for harm minimization strategies. So we found that most ARCHs in WA historically have not had needle and syringe programs. So it was sort of my mission to investigate why and address those gaps. And we find that finger prick testing was, while it's widely validated, it was very underused as a testing approach in the sector. So we found that all the clinical leads across all the 23 ARCHs were were keen on Hep C finger prick testing, but and about half of them being keen on having an NSEP in their service. I think the reason that was only half of them being keen for the NSEP was because they didn't see the benefit if there was an NSEP already in their local regional hospital, or they thought that there was low intravenous drug use within their community. So as a result, we've created some 2 resources which are in the final draft stage, which indicate how to set up an NSEP and one on how to successfully sustain finger prick testing at their service. Yeah, and so it's just part of our new public health collateral. In terms of what we would do differently, would have more than one staff member take the lead on this project to ensure the continuity of this project. Would have a greater focus on addressing stigma and perceptions rather than just educating health professionals. So really focus on challenging those preconceived notions they had. We have personalized CQI activities rather than just sort of streamlined auditing, and have more opportunities to travel and work hands-on with those services. So yeah, Hep C will continue to be a program area at ACWA. Thanks for listening. No, it's Yeah. Happy birthday, by the way.
Thanks. Oh, this is going to be great. Did you get any uptake from any of the Aboriginal Health Services about the NSP? Like, was anyone sort of like, actually, yes,
Well,
we would
actually,
like some support?
If you could actually ask Judith over there, because they've had those final conversations, and there are some archers that were very much enthusiastic about it, not because of our resource, but because I guess the conversation was started. The resource is yet to be, it's just in its final draft stage, but yeah, there's been increased conversations around having NSEPs at archers. Yeah.
Thanks. That's great.
Just a similar question about using Hep C as a Trojan horse to get harm reduction into archers. Conversations, interest, there's often barriers in terms of governance and the boards of archers.
Yep.
How are you going to
You just have to have some really enthusiastic staff members. You have to try to get as many champions as possible in your service to keep advocating. If you get the CEO on board, that's even better. But getting a clinical lead, and a clinical lead that's got a really good relationship with their CEO is handy. So yeah, and constantly, like nudge theory, like constantly just planting the seed, pushing for that, for that change. Yeah. Hey.
Now ask Stephanie Germano from Northwest Melbourne PHN to do 2 posters and a talk in 5 minutes.
Sorry. Thanks, Jackie. Hi, I'm Steph. I'm from Northwestern Melbourne PHN, and I'll be presenting on the 2 quality improvement projects that were led by Northwest Melbourne PHN in 2020 as a pilot, and then by Southeastern Melbourne PHN this year as a expansion project. So I'd just like to acknowledge Joanna Yates, who is on the line, who led the project in Southeast Melbourne. So as I mentioned, it's a partnership project with Southeastern Melbourne PHN and Vital. The 6-month pilot within Northwestern, which then expanded to a 4-month project within Southeast Melbourne, where the project aims to increase screening, testing, treatment and management of patients with or at risk of hepatitis C, and increase awareness, knowledge and ongoing support to educate general practices in hepatitis C and quality improvement. So essentially, practices adopted a data-driven approach to quality improvement to test change ideas or improvement ideas that were supported by 3 learning workshops, and then followed by activity periods following the PDSA cycles to support practice-led change. So data was collected through clinical auditing software such as PenCat and Polar, and then pre and post project surveys to measure change in practitioner confidence. Starting with the outcomes of the Northwestern Melbourne pilot, over the project period and the 12 months following, 831 patients were screened for hepatitis C risk, 96 patients were diagnosed, and 83% of participants reported being confident in identifying patients at risk. Moving on to the expansion project led by Southeast Melbourne PHN, 1,727 patients were screened for hepatitis C risk, 78% of participants felt very confident with their knowledge and in identifying patients at risk, and 67% of participants felt very confident using clinical data to support their activities. So across both projects in each PHN catchment, improvement activities that general practices trialled ranged from developing a process to identify patients, using recalls and reminders, so messaging at-risk patients. Some practices developed health promotion resources, so patient education pamphlets, and incorporating screening as part of regular blood tests or health assessments. So overall, practices developed a systematic approach to hepatitis C screening, really supporting that continuous quality improvement in practice. So what would we do differently? So if we were to do this again, we acknowledge some limitations of the clinical data auditing systems that having a system that could really reflect all risk factors would allow for a much less manual process of identifying patients, which can be quite burdensome for practices. We could increase the number of GP champions. So having a clinical champion in the practice to lead change and really supports a whole of practice approach to quality improvement.
Additional support to general practice staff about having the discussion about hepatitis C, although it was a focus area of the project. We heard from practices that that could have been an improvement area to support them have the conversation with their patients. Clinical partners via vital and subject matter experts were a key component of this project, but additional representatives from Corrections Victoria would be really helpful to have someone present from the prison systems to support some gaps in education. Supporting networks and relationships with integrated hepatitis C nurses, so supporting GP with their continuous professional development and supporting practice nurses to increase their capacity and work at the top of their scope. And the last area of improvement could be whether we could broaden this project. So could we embed these activities within a larger liver health project, for example, or a wider project focusing on risky behaviours, alcohol consumption, BMI, healthy eating. So based on the 2 projects implemented in both PHNs, Northwestern Melbourne PHN in partnership with Vital are developing a toolkit for PHNs to implement this project within their own catchment. So a step-by-step guide of a facilitated quality improvement. And just a huge acknowledgement to Joanna Yates and Campbell Rule from Southeastern Melbourne PHN, Maria Hunt, Michaela and Bianca Bell from Northwestern Melbourne PHN and the Vital team. Thank you. Great. Any questions? Let's take
Thanks for the presentation. Were you able to kind of look at treatment data and how kind of the linkage between the good high screening rates you had and the uptake of treatment?
Great question and happy birthday. I'm not too sure. It's probably a question I can take on board, but I don't know if we measured medication prescriptions as part of this project. It's probably something that we could certainly do in the expansion, but I can follow up and get back to you as well.
I've got one, Jackie. Yeah, thanks. I don't think you quite elaborated on the work that you did to get practices into the continuous quality improvement. And particularly, maybe you could give a little high level of the components of your actual workshop, like who came along and what topics did they discuss?
Yeah, absolutely. Great topics. So the 3 learning workshops were invited to the general practice staff, so nurses and the clinicians, and as well as the practice managers and admin support. And they were the clinical education behind it. So testing, best practice management, screening and what risk factors practices could identify patients. And focusing on those kind of elements to support them as well as the support on how to have the conversation with patients and to support patients through education as well. And that triggered a lot of practices to come up with their own improvement ideas based on the best practice guidelines from the workshops to go, okay, what can we trial within our practice based on what they've learnt in the learning workshops. Joanna's got her hand up, which I'd like to so please, yes, if that's okay, if we have time.
Yeah, sorry, Steph. I just sort of added quickly, because our projects, we work together, but we did our project in Southeast Melbourne from May till September this year, whereas Northwest did theirs at the start of COVID. So our workshops were a little bit, I think they may have been a little bit different. So how we structured our workshop was the first workshop was based like on the clinical side of hepatitis C and also quality improvement as well. And we were lucky enough to have Caro, who's here today from Harm Reduction Victoria, also speak at the workshop. And then the second workshop was again focused on quality improvement, where we had one of our polar experts, because Lindy, she actually did a step-by-step walkthrough with the participants. Looked at the referral process at Monash, and also discussed the stigma element of hepatitis C. And our third workshop was it was, we actually asked the participants what they benefit from the project. So it was like a reflection, and also it was really good to hear their learnings. So yeah, just sorry, Steph, I just wanted to added it in.
Perfectly, if you can see it, thank you. Yes.
Thank you very much, Shina. And they were very, very kind to invite me to that third workshop because I'm such a sticky beak. And it was absolutely brilliant to hear from the practices about what they'd learned through the process. And they were also reflecting on what they wanted more of. And we got a referral into Asham for the Hep B, some Hep B work down the track as well. So it was fantastic. Thank you very much, Steph. And Melinda Hassel from Asham is our final speaker for this session.
Thanks. Hi, everybody, and hi those online. I am a little bit like Alyssa in terms of, you'll know that I'm a nurse at Asham. I'm a clinical nurse lead rather than a project officer who works with slides all the time, because when you see the slide, you'll see that I missed the memo and making it look really pretty. So apologies. I think even the header title is still there. So I'm talking about two projects we were fortunate to receive funding from EC on a couple of different activities. The first was a education for nurses. So Asham delivered 2 hepatitis C nursing courses and 1 hepatitis C hepatitis C course for nurse practitioners in 2020 and 2021 to nearly 150 nurses and nurse practitioners. And those nurses were from a variety of different public health and private health settings, and also primary care settings. And whilst 2/3 of the nurses who attended are not able to prescribe, I think we all really acknowledge that nurses are quite critical to screening and testing within primary care, and that have really key roles in multidisciplinary teams with the care of Hep C. So thank you to EC for supporting nurses with the education. The nurses were really open and engaged in the online learning offered. And when we received the funding, we were in a it was 2019, and we were anticipating doing face-to-face courses. Of course, that all changed, and along with all of Asham's education offerings, we pivoted very quickly to an online learning environment, and the nurses were really engaged and responsive, and we had fantastic numbers in those early days. There were some challenges with nurses being able to implement their learnings in practice during COVID, just with changes of priorities, obviously, and changes in roles. So weren't necessarily able to take the learnings back, and that sort of came through in the evaluation. We've had time to reflect on what we would do differently with the education, and that a lot of learnings from our online education has led us to developing our Asham On Demand online learning program that is now fully functional and has a range of hepatitis C and other education available through our learning management system. And then second activity to share is Beyond the Sea, eliminating hepatitis C in your practice. This was a quality improvement hepatitis C clinical audit and case finding pilot project that commenced in 2020 and ran through till 2021, September to September. And EC Australia supported us with evaluation of the project, the pilot project. There was the basis of the project, even pre-COVID, actually, it was always going to be a virtual support program. And so we were already set up for that, really. And whilst we did need to take into consideration impact of COVID on a number of other aspects of the project, that was already in play, which was fantastic. And what we found with some of the practices was that there was quite a varying level of understanding of hepatitis C and quality improvement. I think we had assumed a greater baseline understanding of both, given that our recruitment was for practices who had already engaged in Asham Hep C education. But we found that to be a little bit different. And whilst the model was to be as flexible as possible, and that certainly came through in the evaluation, practices were really encouraged and appreciative of the flexibility and adaptability of the project team and project resources that we sorry, I've just been distracted by the 1 minute. We were able to respond to their needs. And what we found was that we thought providing a template would be great, but actually practices wanted a lot more information. They wanted us to be able to let them know what they needed to do rather than to have to really consider what they needed to do themselves. What we would do differently, we would definitely engage PHNs, local health districts, hospital and health services, community organisations earlier in the process, and we have actually done that with this next iteration of the project. We are rolling out just about any day soon the second iteration of the project. We have also built a bit more of a resource hub for practices to be able to do some self-directed learning when they are able to, and also provide some support tools to demonstrate participant progress, such as dashboards, data dashboards, and so hopefully that will meet some evaluation goals too. Thank you.
Hey, Melinda, I was just going to ask for practices that participated, could you evaluate if there was an increase in screening within that clinic?
Technically, yes. We did capture some baseline data. It was really challenging. There were so many disruptions, and so it was, and staff movements. So some of that continuity was made that really difficult, but we were able to do it to some degree for some of the practices. Yeah. Any other questions? Oh, no. Hi, Joe.
Hi, Melinda. Great preso. Just wanted to know, with the practice nurses that were part of the course, what were their motivations for wanting to do this training in the first place?
Oh gosh, I think originally, a free course, free education for nurses. And yeah, there really is a strong interest in bloodborne virus education generally, I think. And sometimes it's the GP that might be the motivator for, in general practice anyway, for nurses to attend. Hear through the grapevine that it's a great course. Great facilitators like our colleague Jackie Richmond and other really expert nurses. It's very peer, it's nurse to nurse education. Nurses are writing the content, driving the courses, facilitating and presenting. So I think that's a big key and big bonus for getting people involved.
Thank you.
Thank you to our workforce development projects. Nadine and Carla, Morris, Kate, Peter and Amanda. Come on up. Okay. So you guys can go straight here. So this is our, these are moving on to our client engagement is the term I've coined to try and group these projects. So about incentives and the role of peers. Now it's with great joy, I introduce Morris, who I've met for the first time in the lift today, and I didn't realise Morris was 6 foot tall. So it's great to see you, Morris, and actually, yeah, there you go.
Good afternoon, everyone. So, yeah, we worked on this hepatitis C testing incentives project. The we is myself and Linda Selvey, who's standing at the back there from University of Queensland School of Public Health. So the chronology of this, it came after Cairns Sexual Health Service had done their incentives and a few other people. So EC asked us to oversee really the distribution of $10,000 worth of funding to various different organisations. So we put the word out in Queensland, and people were asked to submit sort of expressions of interest for that funding. And the various people, Troy, Amanda, a few other sort of local actors in that Hep C scene in Queensland, were on a committee that decided who got it. So 7 different organisations were given, I think it was $1,400 and change each to do that. And we were prescriptive about when those incentives could be given, at which point in the cascade. So people could be incentivized $20 for antibody testing, RNA testing, reflexive testing, or accepting a script for treatment was what we came up with. And from those 7 different organizations, a wide variety of different ones were given some funding. We had some Queensland health organisations, some small NGOs and not-for-profits, and some Aboriginal medical services as well. And it was vouchers that were given for the incentivisation. I think one of the really interesting things that came out of this project, particularly in the sort of southeast area where there was a greater concentration of organisations, was that it really seemed to be a bit of a catalyst to bring various organisations together to collaborate in this space. Amanda, you were very much a part of that, I think. And so some of the organisations, well, Amanda and Carla from Cairns both offered to talk to any of the 7 organisations about their own experience with incentives projects, to help them run their own projects, to offer their experience and a bit of mentorship, which was wonderful. But when some of the organisations came together, they decided to hold kind of liver health clinics and things like that. But some of the organisations came together. So somebody said, oh, you know, well, we'll bring the FibroScan along, and Quinn provided some peer workers to come along as well. Somebody else brought a point of care testing machine. And that was fantastic to see. That sort of this one-stop shop approach was a phrase which seemed to come out of it amongst the local organisations, of people getting together and trying to get all of those services and all of those important parts of the cascade together in that one place. So that was really good, I thought. In terms of some of the stuff that we might do differently, I think, having seen with the various organisations that we did the evaluation on in the end, we would have been less prescriptive about the amounts and when they were offered. I don't think this is a one-size-fits-all approach. I think it's a matter of trusting the organisations who really know their own particular clients and their own particular cohorts. It's a matter of trusting them to use the incentives in the way that really works for them. I remember specifically when we did the evaluation interviews, one of the Aboriginal medical services said to me that they were particularly interested in reaching young Aboriginal men who'd recently been released from incarceration, and they didn't think that the $20 incentive was enough to persuade them to come in specifically for that Hep C testing. If there were people who were at the service for other things anyway, yet $20 was fine. It would encourage people to do that, but it wasn't enough in isolation to encourage people specifically to come along from that. Some clinicians also said that they had clients taking a $20 incentive voucher to get tested and then never came back for the results. And so they questioned whether or not it would be better to give that incentivization when you came back to collect the results rather than when you actually took the test. So I think we'd give greater autonomy to those organizations to do that. One of the other issues, frankly, was the administrative burden of giving a small amount of funding to all those 7 different organisations. In Queensland, with the Queensland health organisations, we have to get research governance from each of the different HHSs. This was after we'd got ethics. Some of the Aboriginal medical services had their own research governance systems that we also had to go through. Queensland health organisations couldn't accept the money and then ring fence it to buy vouchers. So again, Quinn stepped forward and bought the vouchers for the HHSs, and we just gave them the vouchers rather than the cash. You know, I remember sort of having fortnightly meetings with Linda, and it was, you're still on the incentive stuff. You know, it took a lot of time to distribute that to the 7 different organisations. All of the ethics and the research governance wasn't about distributing the incentives. It was actually to do the evaluation to work out how that had gone, which is obviously a really important part of it. But we did probably underestimate exactly how much work that did entail. Whereas if it had all gone to one organisation, that would have been far more efficient. And then just quickly, finally, we lost a project champion from one of the organisations, and that was really noticeable. So having one person at those organisations to drive that stuff through, I think, is really important too.
Thank you, Morris. Any questions for Morris? Morris is coming back a little bit later, that's right, for another talk. So thank you very much. We're playing musical chairs. Kate Patton is here to talk about Project Sonic. Thank you, Kate.
Yeah.
Hi everyone, my name is Kate Patton. I'm a policy officer within the Hepatitis Programs Unit at the New South Wales Ministry of Health. Before I start today, I'd just like to acknowledge the Aboriginal people as the traditional custodians of the lands in which we all work, live and learn, and pay my respects to elders past, present and emerging. Today, I'll be giving a brief overview of Project Sonic and some of the key learnings and findings from this work. Project Sonic was a project that incentivised hepatitis C testing and treatment in needle and syringe programs across New South Wales. The project was developed by the New South Wales Ministry of Health and delivered in partnership with 10 New South Wales local health districts, as well as peer workers from Hepatitis New South Wales and the New South Wales Users and AIDS Association. Project Sonic also included an NSP workforce development project that was led by the Kirkton Road Centre. Just quickly, before I go into the main project outcomes, it's important to mention that majority of the NSP sites who participated in Project Sonic used dried blood spot testing, otherwise known as DBS, as the main hepatitis C testing method. Although the DBS test does detect a current RNA infection, because it is not approved by the TGA, DBS cannot be used as a diagnostic tool for treatment commencement. Therefore, all participants who return a detected DBS result do need to be followed up for a confirmatory blood test, and this creates another barrier for people commencing treatment. We acknowledge this is a limitation of our project and may contribute to the loss of follow-up rates that we had. So just a quick overview of what we achieved during Sonic. So we had 22 NSP sites participate, and this was a combination of secondary and primary NSPs. Oh, no, cool, let's go. We had over 1,000 people tested for hepatitis C. 113 people returned an RNA positive result. However, only 20 people initiated treatment. All participating sites are still trying to follow up people and encourage them to commence treatment. We also developed 2 learning modules, hepatitis C and NSP 101. These learning modules are available on a central Moodle website and are accessible by all New South Wales NSP workers. So some of our main learnings from the project are that on-site testing and NSPs and offering incentives are crucial for reaching people at the greatest risk of hepatitis C. Peer workers are integral to supporting people throughout hepatitis C testing and treatment. Offering on-site testing, prescribing, or a warm referral pathway for treatment is essential, and conducting outreach activities to find hidden and hard to reach communities is beneficial. Moving on to what we would do differently next time. So first up is including the peer and community-based workforce more. We would try to mitigate the loss to follow-up of positive cases by expanding the peer workforce to continue to follow up people for treatment after the project testing phase has ceased. We would also engage earlier with our community organisations, Newer and Hepatitis New South Wales, to get their thoughts on how we can better utilise the peers to help people commence treatment. Secondly is our models of care. We would strengthen the treatment pathways and partnerships with health services, including sexual health clinics and primary care services. We would focus on outreach testing and treatment blitzes in pharmacies, homeless services and social housing to find people who may not be interacting with NSP services. During Sonic, we found that one local health district conducted outreach activities with homeless services, and this was really successful for finding people who had actually not interacted with the NSP previously. We would also increase the incentive for treatment commencement. Most sites had a treatment incentive of approximately $20, and if we were to do this again, we would actually trial increasing that incentive. And lastly is using innovative testing technologies. With the recent introduction of point of care testing, we would offer a mix of DBS and point of care testing. In New South Wales at the moment, Newer are currently partnering with the Kirby Institute and local health districts to deliver a peer-based point of care testing bus project known as Peers on Wheels. And we are hopeful that with the assistance of point of care testing in this newer project, that we will see an increase in people commencing treatment. Thank you very much. Very much, Kate. Any questions for Kate? Yes, Phoebe.
Thank you. Just a quick question. You mentioned wanting to look at increasing incentives. Is there any research to indicate what an appropriate amount would be? And I guess if that has any impact on ethics?
There is a paper, I don't know who wrote it, but there is a paper that has been released recently looking at incentives and what the appropriate dollar amount would be. Does anyone know?
Nick Scott wrote it.
Yeah, okay.
It's
So
in the
there is a-
report and Nick
yeah.
will be presenting it later.
Great, okay. So, great.
You can sign it. Any other?
Thank you. That was great. Can you just talk a little bit more about expanding the peer workforce and how that might work within the NSPs? Because we know that are people who are peers within NSPs, but might not always identify.
I guess what we found with projects on it, because it was a time limited blitz, the local health districts employed peers from HEP New South Wales and newer for a limited amount of time. What I meant with that comment was within the contract with the peers, we would actually extend the amount of hours that they worked past the testing phase, so they can continue to help with the follow-up of people into treatment. I think we can really see that we had a lot of testing and we definitely did get some positive results, but our treatment uptake wasn't great. So just trialing using the peer workforce to get that back end is something that we would probably explore. If that is it. All right. Thank you.
Thank you very much, Kate. Now I'd like to welcome Peter Garber, who's going to talk about the Hep C Peer Harm Reduction Education Project. And it's so embarrassed that it took me a year to realise that that was Hep C free. They kept talking about Hep C free.
It took me about a year myself.
I was like, Hep C free, it's so good. And then I realised it was an acronym. Thank you.
Okay. I'm just going to start by acknowledging all of the peers that we've lost to hepatitis C and liver cancer and things like prohibition over the years. Lives that matter and bring meaning to the work that we're doing today. So I'm from Peer-Based Harm Reduction WA. We're the only peer-based harm reduction service representing the needs of people who inject drugs in WA. And we've been doing that for about 24 years. For context, about a third of the needles and syringes that are distributed to people who inject drugs in WA are done so through one of our NSEP services. We've built some effective services for hepatitis C at our organisation in Perth and Bunbury. Our clinical services are overseen by an experienced hepatology nurse practitioner, Leanne Myers. We have point of care testing, peer phlebotomists, mobile clinic vans, outreach clinics, and our hepatitis C case management workers greatly increase the level of support that we're able to provide to people during hepatitis C treatment. But many peers are simply not engaged with our service or any service at all for that matter, and that's where the Hep C Free project comes in. Hep C Free was initiated through a grant from the WA Department of Health in late 2018 and supported for a further 2 years thanks to funding from the ECA Australia partnership. So what did we do? We recruited and trained peer educators, so people who identify as injecting drug users who had experienced treatment themselves with an extended network of other injecting drug users. We provided an extensive training workshop and sent them back to their networks with a peer diary. Peer educator to peer interactions and peer referrals were recorded in those diaries. The diaries were designed to spark conversation about Hep C testing, treatment, prevention, and our service via a range of questions. Peer educators also recorded the contact details of those who wanted to be referred to our service for testing and or treatment. And peers then submitted their diaries monthly. Mentoring was provided and peer educators were given $140 remuneration payment every month for those diaries. Peer workers then followed up the peer referrals for testing and treatment, as well as requests for other information. So over the 3-year period, a total of 34 peer educators reached 877 peers with their diary interactions. 158 of those peers provided phone numbers that were contactable. There are many more that weren't, and 65 of those translated into appointments with our clinical services for testing and or treatment. Of the 877 peers reached, around 21% identified as Aboriginal or Torres Strait Islander. Only 31% had been tested for Hep C in the past year. 38% had been tested more than a year ago, and a further 31% had never been tested at all. Only half of the peers reached said that they knew their Hep C status. Of those, 30 said that they were Hep C positive, and all of that tells us that we were reaching priority populations. Peer diaries are a great asset. They collect such rich qualitative data. In their own words, some of the peers reached had this to say, and this is just a really small sample. I wouldn't have heard this information any other way. I wouldn't have spoken to a doctor due to my privacy concerns. Doctors are always in a hurry, and it's hard to remember the questions I wanted to ask. I rarely have contact with anyone other than users. Peers are knowledgeable. The information they give is more appropriate for me. So when so many people are telling us that this is the only way they can be reached and the only delivery of information that they feel they can trust, why aren't there more projects like Hep C Free doing exactly that? Now that Hep C Free has ended, I'm not aware of any other projects quite like it in WA. However, thanks to Anata's capacity building project, the training workshop that was originally developed for peer educators has been adapted and delivered to other organisations in the AOD sector in Perth. And we are starting round 2 in January, thanks to funding from WA Department of Health. So as to what we would do differently, we could have that slide. Oh, it's here. Thank you. Well, like our other services, our service is constantly evolving due to what, based on what we learn and what our consumers tell us that they need, and peer education projects are no different. I think if we could do it all again, we would simplify the peer diary, perhaps focus more on 4 or 5 key points to make that simpler and more achievable for our peer educators. We've learned that a more adaptable training format is essential. So being able to deliver that training in an outreach format, perhaps to peers in their homes. And last but not least, the autonomy of project officers to be able to provide phlebotomy and testing on demand, which was not possible at the start of this project, is probably something else that we would prefer to do. Thank you.
Any questions for Peter? Mark?
As with everybody in life, not everyone's equal, and not all clinicians are equal, not all peers are equal. Do you have any insights into what makes a particularly successful peer in this context? And were there examples where you just, you know, there were some peers that just didn't sort of work?
A lot of it will come down to the size of that peers. Like, you have to recruit key peers that have a sizable network of other peers that they can then perform these interactions with. You know, one of the drawbacks is that if people don't have those large networks, then they cycle out of the project pretty early on, as they simply run out of people to talk to. Yeah.
Thank you very much,
Thanks.
Peter. And our final presentation before afternoon tea is Amanda Cavassi from Quinn, who brought a support group.
Oh, embarrassing. Can't go and leave without them. Thanks, Jackie. And I have to say, hard gig to follow Western Australia. That was amazing information. So I'm here today to present on behalf of Beck Kavanagh, who is actually the team leader at Quinn that looked after our Hep C community peer project in Queensland. And this project was really an opportunity for Quinn to look at providing our peer workers to go a little bit further afield. So instead of having peer workers at Quinn for people that access Quinn, we wanted to get them a little bit further afield and offer our services to other people who might be treating. I'd like to acknowledge the fact that we had 5 peer workers over this project. They were contracted peer workers. One of them is with us today, Colin, who spent a good deal of time in this project. So thank you, Colin, for all the work that you did. Colin sat in our identified First Nations peer worker position, which was a great thing for us to have, I think, at Quinn.
And really, in terms of learnings, we got a lot out of Colin's work, and obviously he's continued in the field, although we weren't able to keep him at Quinn. He went on to bigger and better things. At least we still have him in the Hep C world, and I think he's presenting tomorrow. Is that right? Yeah. So part of this project was about, we did a lot of, the peer workers did a lot of service contacts across Queensland. And for the second half of the project, we lost our 2 initial peer workers. And so we recruited for the last 6 months of the project, 3 peer workers to finish us off. And we positioned them regionally to try and get a little bit better perspective across Queensland. So they were based in Townsville, Sunshine Coast, and then one still in Brisbane. While the client evaluation that was done by UQ was quite positive, we would have still liked to have reached more people. I think we had high expectations and high goals when we started this project. And as a way of trying to supplement that, we didn't get our peer workers trained up in doing point of care testing. So not DBS, the rapid finger stick point of care testing, as a means of supporting other services to increase their testing, and also for our peer workers to reach more people. Partnerships were critical to the success of this project, but they do take time to develop. And I think it's important to recognise that peer workers still do face an enormous amount of stigma in the workforce. And so when we're asking our peer workers to go out and talk to other services, we have to acknowledge that that stigma and discrimination may be there in those services that they're going to. So partnerships were crucial. Of note, I just wanted to mention the work that we did with MICA, which Morris mentioned in the incentives project, where we, our peer workers went and did point of care testing and then supported their clients to be treated by MICA. And also some great work that Colin did with a GP clinic in West End, who had a very high OST clientele and often recently released from prison. So Colin would go over there on a fortnightly basis and try and encourage people in the waiting rooms to get tested and be that sort of voice of reason in the waiting area. We also at Quinn established a really good peer supervision and mentoring network for our peer workers, and that was led by a peer worker at Quinn. There was nobody else except peers allowed to attend the peer supervision, and I think that that was a really beneficial thing that came out of this project and continues today. We also did peer diaries like Western Australia. A little bit differently, our peer workers reflected on their activities, the interactions that they had, some of the stigma that they faced, and it was also a communication tool for them to use as well. So some key learnings. We started at the start of COVID. We'd just recruited, and our goal was to go out and visit other services who all of a sudden were shutting their doors and didn't want anybody coming in. So we did have some alternative things that we needed to put in quite quickly, which the peers implemented themselves, things like going to flu vax clinics and COVID vax clinics when they started. I think communication and marketing is something that we could have done better, particularly acknowledging the stigma that was faced by some of the peers when they were contacting services. It's something that we could definitely work on a little bit better. The evaluation showed that some of the services were unclear as to the treatment pathway if they were seeing a Quinn peer worker. I've got a stop sign, so I'll just finish off on the pay rates. And I think it's just everybody's talking a lot about increasing the peer workforce, but it's important, I think, to recognise that a peer network isn't a cheap peer workers aren't cheap workers, and we need to pay them, you know, accordingly, and that means we need to be funded accordingly as well. So I'll end there. I had a couple of other points, but I don't want to get in trouble by Anna.
I can't, as it turns out, I obviously can't add up because we're ahead of schedule.
Oh.
So you go for it.
Okay. All right, I'll wait for a recard. Where did I get up to? Pay rates. Pay rates. Yeah, I think I made that one pretty clear. I do honestly, I think that's really important. If we're talking about increasing peer staff, we need to be funded appropriately to do that. Some other things, I guess, and when we ask for budgets, you know, we need to make sure that we're fully costing for our projects, because we put new projects on consistently onto the same team leaders that we have and the same. So we end up with this great projects happening, but a really limited ability to offer appropriate regular supervision and mentoring for those staff. So we really need to, and I don't know what the answer is. It's something that we're still working on at Quinn in how we work that out. The other thing is we could have reduced our geographic reach. We had big plans to do Queensland, massive state. We probably could have phased that a little bit. And the last kind of learning, I think, from what now is that this project really gave Quinn as an organisation an enormous amount of learnings, both from a staffing point of view and from a management point of view as well. And it has allowed the organisation to gain some momentum in this space. And we now have a dedicated peer leadership role in Quinn that's looking at establishing a peer framework for Quinn. And I think that that is going to just help us to keep moving forward in this space and hopefully share that information with all of you as well, you know, down the track, if you're looking at putting in peers into your workforce as well. I'm going to stop now.
Any questions for Amanda? Elisa, birthday girl.
Happy birthday.
Thanks, Amanda. Totally agree around peer workers not being cheap workers. And I think we need to be mindful that we've got similar language sometimes when we talk about nurse practitioners and nurses, and it's kind of seen as like they're the solution, but then the kind of appropriate costing doesn't come accompanied with it. Do you have maybe some thoughts about how we push forward that process of ensuring that peer workforce are appropriately structured, funded and supported in Queensland environment?
So I think for an organisation like Quinn, so we pay on the award, so we need to make our peer job descriptions essentially fit the appropriate award so that they are equivalent to, for example, our harm reduction workforce. If we don't do that, we risk losing people from identified peer positions. They may stay within the organisation, but they may not necessarily be in identified peer roles anymore, which is still great for Quinn, but in terms of building and expanding a peer workforce, you know, I think that's, so maybe it's more that sort of, you know, job description almost level and yeah, setting it out at the start. Any other questions?
Jackie, do you want questions maybe for anything, anyone we missed for 5 minutes?
Anybody got any questions? Anything to say? I have. I would like to just say that one of the things that we learned very early on, and Louise Owen raised this at one of our first, I think, executive meetings, was also building in project time and admin costs and admin time. And it's to your point too, Amanda, that you can't just keep giving people more and more projects and more work. So that's certainly something that we have taken on board. And in recent funding things that we've done, we've said, you know, we need to actually make sure that you are being funded appropriately for all the project management costs. It is quite possible that I can't add up. So somehow we find ourselves in a position where we're ahead of schedule, which I was just
Jackie,
like,
we're perfectly on time.
Yeah,
We just,
we're not really. We're 8 minutes ahead of schedule.
No, we've got one person to talk to.
We would like to just acknowledge that it is our illustrious leader's birthday today. And we know that she would probably, although we love you all very, very much, and we're very committed, Elisa probably would like to be spending this time with Brian and her son, Miles. So we would just like to say thank you very much for being here. And I think a little bit of joyful communal singing is in order. Ready, set, go. Happy birthday to you. Happy birthday to you. Happy birthday, dear Lisa. Happy birthday to you. Hip, hip.
Oh, wow. This is why you should not have your birthday on work events, for this exact reason. Thank you. Thank you for the cake. Everyone at break, please eat some of my delightful birthday cake. Okay. Yeah, you have to cut the cake. You do that well this year, Elisa. Cutting cake. Oh, we didn't have wedding. Yeah.
Fabulous. If we could all come back at some time. What time are we all coming back? At 3:45. Yeah, I think I tried to take 5 minutes, but I'll give that back. But 3:45. And then if I can have all my models of care speakers up on stage. Thank you very much.